Hello and welcome to the Pilates Hour. It's getting close to the holiday season. We're right in the middle of it, so I know everybody is busy and starting their travels. I am excited to be with you today and talking about a theme that I absolutely love. I love talking about low back. I've always enjoyed treating low back pathology and trying to figure things out because there's no two backs alike. So as we get started, let's go to our first slide. I sort of want to run through some of the mechanisms of lumbar pain and talk a little bit about it because it can be incredibly complex. And anytime that, again, there's usually lots of questions when we talk about lumbar pain, especially when we talk about the disc. What does it look like? How do we know what's going on with it? How should I say this? There is no direct correlation between the intensity of pain and the tissue damage. There are people who've had severe tissue damage with very little pain, and vice versa. We also know that when we are anesthetized, when we are unconscious, or that there is a block that prevents the nerves from conducting to the brain, that there is no pain. Pain has to be experienced in the brain, in the frontal lobe, for us to be able to acknowledge that. So here we look at it, and I like this picture because it sort of represents the wholeness of the nervous system. The nervous system is continuous. And it is the connective tissue around the nervous system that we see when we dissect. And that connective tissue, as I mentioned, in the central nervous system is referred to as the dura. And the dura is the protective sheath that surrounds the spinal cord in the brain. And then as it leaves the foramina of the spine, that foramina means hole, as it leaves the hole to the side, we call it the epineurium. We know these things because of things like reflexes. So if you know with a hammer and you tap the patella tendon and the knee jerks up, that literally is a sensory neuron in the patella tendon that gets stretched, or in the quadricep muscle that gets stretched. It sends a message to the brain, and the reflex then sends a contraction back to that muscle and causes a contraction. That's why we see this reflex in about 50 milliseconds. A lot of our automatic responses are built just in spinal cord reflexes. So things like walking, swimming, things that are repetitive that we do in our bodies. So pathologies-wise, when we talk about a disc pathology, we can think of 3 or 4 things. We can think of the chemical pain, as I mentioned. So just the mere damage to the disc can release and cause an inflammatory response around the nerve tissue. The second is the dura itself. If the dura gets pinched or the epineurium gets pinched, like a lot of times people with stenosis, if they go into extension, the space is already narrow, and they actually pinch the nerve. And they pinch that nerve, and it causes an inflammation, and that inflammation now is its own problem. I'm not going to talk so much about the zygapophyseal joint, that's the facet joint, but just understanding that facet pain is like joint pain. So the facet is an articulating just like your ankle, your shoulder, your elbow, your wrist, your knee. And if there is a problem inside the facet, where there's a damage or a fracture or some instability from the ligaments, in itself, it also can cause an inflammation. So here we look at the combination of the disc and the vertebra, and we understand inside the disc is the nucleus pulposus. This is the jelly fill. As we age, I was explaining this to Melissa, who helps me and does just miracles of putting together the slideshow and the webinar in and of its own. But we were talking a little bit about how the nucleus pulposus, as we age, becomes drier and stiffer. So even, for example, in the cervical spine, there is a loss of fluid and jelly-like substance in the nucleus pulposus as we age, and we're less likely to have a disc herniation. We're more likely to have degeneration. In the annulus, the rings here, if you looked at and you dissected it, it sort of looks like our abdominal muscles. So you have some fibers that are going perpendicular and at an angle, others are going horizontal, others vertical, and the layers are made specifically for that. But as I mentioned to people, we talked about this a little bit in the mobility lecture last week, is if we don't load those tissues on a regular basis, there is no accommodation to the load. And so those tissues become fragile. And when they become fragile, they're more likely to degenerate or to tear when there's an abnormal load placed on it. So here's an example of an MRI of an L5S1 lesion. So we're looking at it here. The gray part in the middle on top of the red loop, that is the disc. And the little protrusion you see coming out, that is the disc herniation. And the really white, bright, sort of look like little dots, that's the spinal cord. Everything around it is spinal fluid. And if you look to the right of the screen, you can see some of the compression there on the nerve root that is coming out on the right. And so that gives you an idea. When we look at an MR, we want to know what is going on in there and how severe that disc protrusion is. So it gives us a lot of visibility. And if we look at the spinal cord here on the left, you'll see what looks like a horse's tail. We call it the cauda equina. And the cauda equina is the grayish, kind of whippy looking things inside the clear fluid. The clear fluids are the spinal cord fluid. And so a lot of times you can have a disc herniation with no symptoms neurologically whatsoever, even full disc herniations that are really putting pressure posteriorly because the fibers coming down in the bottom part of the spine are sort of wispy as they come out to the side. And so they can move around the disc. So you can see somebody has a very severe disc herniation and not have any radicular symptoms, or they could have a little disc herniation out to the side that actually does put pressure onto the nerve root coming out of the foramina. So the MRI should be compared to the clinical signs, not to just treating the MRI. And I can talk a little bit more about that later. It's very interesting that as much as you think it would be normal to move the hip flexion, we tend to strategize to stiffen everything up and hold our hips, squeeze our glutes, and our movement then comes from the segment that's damaged or injured. It doesn't quite make sense to me why we naturally do that, but we do. And so what happens is it's one thing to damage that disc and have a little bit of inflammation and irritation around that nerve root. While we're doing that, Catherine Connor asked a question. As a Pilates instructor, dancer with back issues, everything you are saying I can relate to and I'm able to incorporate into my teaching. Oh, I'm so glad to hear that, Catherine, because I do the same thing for myself, and a lot of us got into Pilates because of dance injuries, sports injuries, running injuries, and we found that we get our best relief in what we teach. And if we practice what we preach, we often get better. Another side note on that Catherine brings up is when we have people applying to become Pilates teachers and they want to do the program. And sometimes they'll say things like, I have a disc herniation at L4, L5, or I have this, or I have that. And it's sort of like, our language to them is to encourage them. It's like, this is your cure, is to do the Pilates, to re-educate your body. And so if we're doing our practice right and we're teaching the right thing, you should be able to go through this training successfully, maybe with a few modifications, but understanding that what we're teaching is helping you in the way that you are going to help other people in the future. I do want to remind you of a couple things coming up. One, our friend Wojciech, who was one of my guests with Zoga, looking at the myofascial and movement. He is actually in the United States teaching December 16th and 17th in San Diego, and then again January 6th and 7th. We are also hoping to host him in the future here at the farm. So that's some cool things with Zoga. So we'll send you the link for that. Also, I am going to be presenting the critical reasoning course again once in Dallas, Texas area. That is going to be in February 2nd and 3rd, and then again in New York, the critical reasoning course. It's a 2-day course in person with some live volunteers. That'll be March 15th and 16th. So just want to wish you all a very happy holidays and to take the time to reflect on those things that are most important to us. And above all things, be kind and have a wonderful Christmas and holiday season. Thank you for watching. Click here to watch more.